audible, Shruti?
So, good evening to all the esteemed faculty members as well as all the participants joining us from all across the country. I, Shruti Patwal from the Medical Affairs team of Universal NutriScience, would like to welcome you all to the ISAR Fertility Catalyst webinar. This is the 15th in the series on the topic of male infertility update asked from experts. Without any further ado, I would like to invite our President and BU Head, Mr. Nikhil Mehra, sir, for his opening remarks. Sir, over to you.
Thanks, Shruti. Am I audible, Shruti? Can you please give me a
Yes.
confirmation? Thank you. Thank you very much. So thank you so much, Shruti, again. So before I begin, let me quickly share a thoughts with all of you. So infertility is not just a medical diagnosis, it's a shared emotional journey, as we all know. And today's session reminds us that healing begins when many will stop saying, it's her problem or his problem. It's most important that everyone should start saying that it's our solution. Yeah. With this, a very warm good evening again, and welcome to each one of you on 15th ISAR UNS Fertility Catalyst webinar series. I also like to thank Central ISAR leadership team, Dr. Patki and Dr. Bakshi, our ISAR secretary, our national conveners, Dr. Anu Agarwal, Dr. Fessy Lewis, sir. And my sincere thanks to our chief guest, Dr. Sunita Tandulwalkar, ma'am, our guest of honor, Dr. Aji Patel, sir. So, as we all know, today's discussion is focused on two critical and often under-discussed dimensions in reproductive health. The first one is, of course, the forgotten half, a gynecologist's guide to male azoospermia evaluation and microsurgical sperm retrieval, with from our most esteemed speaker, Dr. Sunil Jindal, sir. The topic two is OATS, which is oligoasthenoteratospermia, what every gynecologist should know about it, by our esteemed speaker, Dr. Kedar Ganla, sir. Yes, on behalf of Universal NutriScience, I am Nikhil Mehra, representing as a Vice President, Women Health Business Unit. And today with me, our medical team, which include Shruti, Dr. Bhakti, and our business team, partner, and our marketing team, Nakul Rishi, are part of this webinar. We at UNS remain deeply committed to support scientific clinicians and patients in their journey. And forum like this truly embody the spirit of collaboration from UNS to the fraternity. With this, I once again welcome you all and wish everyone an insightful and enriching session ahead. Thank you and welcome once again on this ISAR Fertility Catalyst webinar series. Thank you again. Over back to you, Shruti.
Thank you so much, sir. So with that, again, as already sir has also mentioned, today's 15th ISAR Fertility Catalyst is on male infertility update asked from experts. We are truly honored to have Dr. Sunita Tandulwalkar sir as our chief guest and Dr. R.G. Patel sir as a guest of honor. All of this obviously wouldn't have been possible without Dr. Amit Patki sir's support and Dr. Asha Bakshi's ma'am guidance. I would also like to thank Dr. Anu Agarwal ma'am and Dr. Fessy Lewis sir for their continuous support and coordination with the for the ISAR Fertility Catalyst webinar. Dr. Anu Agarwal ma'am is the director at Vansh Fertility and Test Tube Baby Center, Ayushman Hospital and Trauma Center, Ayushman Multi-Specialty Hospital. She's also the executive committee member of ISAR and is also associated with various organizations. She has presented various papers, published various articles, and written chapters in various books. Thank you so much, Dr. Anu ma'am, for your guidance. Dr. Fessy Lewis is the professor and HOD at Department of Reproductive Medicine and Surgery, Amrita Ames Institute of Medical Sciences, Kerala. He's also the Foxy Vice President 2021 to 2022. Is currently the ISAR National Executive. Okay, yes. So has a lot of affiliations to different organizations and also a lot of awards to his name. With this, I would like to hand it over to Dr. Anu ma'am and Dr. Fessy sir for further proceedings.
Anu, thank you, Shruti. A warm good evening to all esteemed doctors present here. I, along with my co-convener, Dr. Fessy, welcome you all in this 15th episode of ISAR Fertility Catalyst series, Male Infertility Update, Asked from Experts. This time we are doing two talks only so that we can get proper discussion time with our eminent speakers, Dr. Sunil Jindal and Dr. Kedar. First of all, I would like to acknowledge ISAR President Dr. Amit Patki, ISAR Secretary Dr. Asha Bakshi Madam, ISAR Vice President Dr. Sunita and Dr. Madhuri Patil, and for giving us this wonderful opportunity and this beautiful platform and guiding us continuously. This time, ISAR President Dr. Abid Patki and Secretary Dr. Asha Bakshi won't be joining us as they are in ASRF. And it's an honor for me to invite today our chief guest, dynamic, beautiful, versatile, foxy President and President-elect ISAR.
Please, no slide here. Can you stop the slide? I better have you all. Anu, don't waste more time in my introduction. Thank you so much. Coming on the ISAR, it is like a घर पे बुला रहे हो. How can I say no? UNS, I'm observing you are doing a fantastic work in this ISAR. With ISAR, 15th is a quite large number. It means you have consistently performed. Even if once in a month you are happening, it's for last so many months you are doing. I think ISAR has evolved a lot. Amit Patki has brought lot of dimension, lot of academic wings to it. And I'm glad that the entire ISAR joins hand. Male infertility having Sunil, I thought when Tracy was there, I did not see your card. So I thought Tracy, because of male infertility, is here. But I think he has chosen male infertility because he loves male infertility. Sometimes, we have an equation looking at the consultant. For example, Sunil Jindal equal to oligoasthenoazoospermias. I'm talking, you have beautiful two daughters. I know, I met them also. I'm just talking your topic of love, Sunilji, a very, very close, dear friend. You cannot leave Meerut unless you visit Jindal Hospital, Jindal Studio, and Jindal House. So that's our love relationship. Anuradha, lovely to see you all. And I'm sure, but I saw all the topics and I think you will be speaking a lot. Kedar, dear friend, I think male infertility also is his topic of choice. But what is very important is an unexplored, even by me, it is still not yet touched. That is antioxidants. Higher than even the oral CoQ. Because when we talk about the oral CoQ or any coenzymes or any medicines, how much it is getting absorbed and how much it is going to reach to the testicular tissue and to the sperm, we are all unaware. We just speak about it. Similarly is the NAD. If you see the electron chain transfer, NAD comes before CoQ in complex 1 and we are using it in a female infertility for ovarian aging or inflammation as we call nowadays. And it's a massive therapies. So I'm sure today you will be speaking beyond the medical line of treatment, which is the futuristic option or the research. And probably 5 years down the line, we will remember this evening where we discussed many more antioxidants than just the CoQ enzymes or any other part. The injectable preparations, they have to come in the market. And for female infertility, we are coming out with our publication because last more than 14, 15 months, we are using it. And it's a massive. That is what we say, taking the biological clock behind, especially in female infertility. So I request UNS to give sponsorship for such multicentric studies when I'm coming as a president, ISA, because my aim there are to do many more multicentric studies. So, and I see so many eminent ART consultants in this field. And it will be lovely to do such multicentric studies with all of you together. And 2 years is a good amount of period we have, not only to study, but to compile. In Foxy also, we have done 7 publications. Very simple, we have chosen, but 7 publications we are publishing now. They are the larger data from all geographical, racial part, same way we can do it. So I think in your today, it's nice that you have chosen only 2 topics, but you can do immense discussion. And this topic, if we discuss, I think definitely we will take our academic strength to the higher level. Thank you so much for having me. And I'm leaving for my Arogya Yoga Yatra, another Foxy program which we do on the weekdays. Thank you. Lovely to
Thank you,
see you.
madam. Thank you
Thank
for that.
Thank you very much, madam, for your kind words. And it's always a pleasure to see you, even if for 5 minutes. Thank you.
Thanks a lot, madam.
Thank you,
Thank you so
Sunil.
much.
Thank you.
madam.
And thank you for that witty smile. But before I see you in Ahmedabad, I would like to see you also in Delhi AICOG.
Yeah.
Don't miss out on
Definitely.
Delhi AICOG. Thank you so much. Thank you.
Ma'am. Thank you very much.
And before that, my Sampurna conference in November, I saw Nilesh coming up, my POGS secretary. POGS has organized one of the best conference of 2025, the Foxy Presidential Conference on OBGYN. I like to see you all there. Thank you.
Thank you, madam. Thank you for taking that time in even before going to airport and bless us, because that is really inspirational and motivational for all of us, and especially for in the coming months and coming year. No, we are all will be with you. Thank you, madam.
Thank you. Thank you.
ma'am. Thank you very much.
Thank you for coming, Sunita ma'am.
Okay.
So, Dr. Fessy, would you please invite our today's guest of honor?
I think it is indeed a pleasure to invite our guest of honor. Is none other than Dr. R.G. Patel. Is, as you all know, he is not only the senior infertility and IVF specialist, he is the director of the Sunflower Hospitals in Ahmedabad, and is one of the first member expert committee of the Central Board of ART and Surrogacy Act 2021. Because when this act came, we all were little perplexed with what it is, and it was he who made a understanding between the act and how that all had worries, and he had made a key role in taking out the worries from all of our infertility specialists. And he was awarded the best IVF center in Times of International Survey in 2019 and 22, and president of Gujarat chapter of ISAR now, and pioneer work in male infertility, including TISA, micro-TISA, with special interest in repeated IVF failures, delivered more than 20,000 IVF babies successfully. So we welcome Dr. R.G. Patel. I have a few
Thank you.
words from
Thank
him.
you, Pishi, for the kind words, and all the best for this scientific session.
Okay. Any other advice or words of wisdom?
Yeah, we see the lots of male infertility is increasing. There is a shortness of the Y chromosome also, and all because of modern lifestyle, addiction, obesity. And we had seen many cases, first time we are diagnosing diabetic or some health issue, hemoglobin is down. And sometimes we are diagnosing malignancy also in the male partner. So it's very important to understand why there is a male infertility, what to do it, how to diagnose, and at the end, if it is azoospermia, then again it will create lots of problem in the family also and couple also. So to give really result to the male infertility is very sometimes challenging to diagnose, and to have a TESA or micro TESA technique to expedite them and to give them own sperm pregnancy is really challenging. So it's thanks to VNS company also, ISAR also, for organizing this type of CMA. Thank you and all the best.
Thank you so much.
And you all welcome in next ISAR, Ahmedabad 2026.
Okay, thank you, sir. Thank you, sir. Over to Anu. I think
Yes.
we will start the first
Thank
session.
you, RG sir. And we all are coming to Ahmedabad. Yes.
Yeah, most
yes.
welcome, warm welcome. In big way, you also, your group also, and all colleague and trainee, welcome in Ahmedabad. It's a very good time, February, not too hot, not too cold, and we will have plan good all the scientific program also, and all 3 days culture program also.
Okay, thank you, sir. I think with this we will start with our scientific session. We have got first session, the forgotten half, the gynecologist guide to male azoospermia evaluation, and further details. But before that, we have the chairpersons. And first we will introduce the chairperson. First slide. I think it is my proud privilege to introduce Gopinath sir, KK Gopinath sir, where my infertility career started. I was with sir for 13 years. Sir guided me into this field. And sir is the unique director of CIMAR Women's Hospital, Edappal, Kochi, Thrissur, and head of Department of Obstetrics Gynecology with the DNB teaching program in Edappal Hospital also. Post director there, and also with the DNB in obstetrics gynecology, FNB in reproductive medicine, FNB in high risk pregnancy, neonatology, executive director of Edappal Hospital. Sir was the first president of ISAR Kerala chapter, and past president of Kerala Association Gynec Endoscopic, past South Zone coordinator of ISAR, past infertility committee chairperson of Kerala Federation, and several achievements like first laparoscopy surgeon in Kerala Health Service many years back. Supervised and conducted more than 1 lakh deliveries. First Foxy recognized laparoscopy and advanced infertility training in South India with Kerala's first ICSI baby. He started first fetal maternal department in Kerala, South India's first PGD and IMSI baby. Second, NABH accredited IVF center in India, and gold medal award by Harvard Medical School. A member of several national and international associations, an invited speaker in several national and international conferences. We welcome you, sir, for this. And next chairperson we have is Dr. Anuradha Kar. As you all know, Dr. Anuradha is the fellow reproductive medicine and diploma with reproductive medicine from Germany, and diploma in from the minimal invasive surgery from Kiel, fellow of the stem cell and regenerative medicine, director of Nurture Fertility Center, Bangalore, currently practicing infertility and related endoscopy at Bangalore, and honorable treasurer of Karnataka chapter of ISAR, member managing committee of ISAR now, and Anuradha did the MBBS from King's George Medical College, Lucknow, and MD from Srinagar, and fellowship of reproductive medicine from Bangalore, and 20 years of rich experience in the field of infertility and ART, and Foxy Badlav Award 2024 articles in several indexed journals and several textbooks. Next chairperson, Dr. Anu. Anu?
Yes, Dr. Fessy. Yes, our next chairperson is Dr. Sonali Gupta. She is fertility and IVF specialist at Patna. She has professional interest in IVF, adolescent and sexual health, and she has various publications in national and international journals. She was CM Government of Bihar for work in IVF and infertility. Welcome, Dr. Sonali.
Thank you.
Over to.
Thank you.
Chairpersons, please introduce our speaker.
Thank you so much. Should I do it?
Yes.
Okay. So it's a pleasure to invite our first speaker, Dr. Sunil Jindal. I mean, we all know him, and I think not only us, the whole world knows him. He's a consultant andrologist and scientific director, Jindal Hospital and Fertility Center, and he's the founder of Freedom from Infertility Society. He's a gold medalist as postgraduate MAMC Delhi, 35 awards from different organizations. He's done collaborations with multiple research institute, national and international, offline, online, master trainer. Golden Play button was awarded to him when he got more than 2 million followers. He has a wonderful channel, Freedom from Infertility of Jindal Hospital, which, if you get time, you can listen to his talks there. And he has various publications and presentations and chapters in 14 textbooks on infertility and 19 papers in peer-reviewed journals, 200 national international presentations. He has a special interest in fertility enhancing endolaparoscopic and microscopic embryology surgery, sexual medicine, special interest in surgical, medical, and laboratory andrology. We give you a warm welcome, Dr. Sunil, and without hampering further, let's start his talk.
Before starting, and one small thing, since we have got expert chairpersons and talks, we are having more time for discussion. all we request all of you to post the questions so that we can have a healthy discussion. Thank you.
First of all, thank you very much, Dr. Anu, Dr. Fessi, for inviting me. Thank you, of course, my esteemed chairpersons, Dr. Anuradha, a dear friend, Dr. Gopinath, whom I have always admired and I always love to see him, meet him. Dr. R.G. Patel, apart from being a close friend, is also been a beautiful person to always meet, speak to. Dr. Sonali Gupta over here. And everybody who's here in the main podium and everybody else who took out time to listen to us on a Saturday evening, on this evening, Tuesday evening. You could have been doing anything else, but you decided to come here. So I'll just begin my talk. And to begin my talk, I'll have to come onto the main window. So I'll just come onto the main window. Today, I'm going to talk to you about something very interesting. Azoospermia. Matlab azoospermia. Why does azoospermia happen? What is the reason? How will you diagnose what kind of azoospermia is there? What are the different techniques by which you can get the sperm? आपको sperm कैसे मिल सकता है so that you actually will be able to use it by ICSI to give a baby to the couple? And I'm going to take you about micro-TCA through the journey. I've had this amazing journey, मतलब मेरी बड़ी कमाल की जर्नी रही है माइक्रो-TCA की. और जर्नी इसलिए हुई कि मुरादाबाद मेडिकल कॉलेज में मैं आपसे पुरानी बात कर रहा हूँ, करीब ये बात हो कि 94-95 की. हमारे एक प्रोफेसर थे, प्रोफेसर RCM Kaza, brilliant man. So my professor used to do microsurgery on the testes, and he used to do VVA, VAS together, VEA, and at times he used to get on to the journey where he used to be working after opening up the testes to find sperms. And after finding a sperm in 3 hours, he would normally tell us, Jindal, I have found a sperm. And I always used to say, what will you do with that sperm? And this happened, but when in 2004 we started doing ICSI, I realized the dots have connected and this is where the sperm needs to be used. And that's how it was used. So it accidentally started in my life with this, because of which countless number of children have been born to parents, in fact, fathers who did not have a sperm. And for a father who doesn't have a sperm to have his own baby is priceless. And do we realize that we all as doctors work day in and day out, giving our time individually to every human being, trying to relieve their pain. And the pain of azoospermia is very deep. It becomes a psychological issue as well. And to give an azoospermic man his own child is just so satisfying. So I'm take you through this whole journey, and this whole journey is very interesting. So I will go on to the first slide, which is understanding azoospermia classification and pathophysiology. Now, please understand that azoospermia per se is divided into 2 types of azoospermia. Number 1 is obstructive azoospermia, where an obstruction is there, which is about 40% of the patients. And there is non-obstructive azoospermia, where the spermatogenesis is impaired due to testicular function. Now, this is 60% of the cases. Now, it's very important for us to define it, because if we don't define it, we won't be able to go in further. Now, what are the causes of obstructive azoospermia and non-obstructive azoospermia? So, obstructive azoospermia per se has a few characteristics. There is normal spermatogenesis. There is a mechanical obstruction in the reproductive tract, accounts for 40%, and has good prognosis. तो ये एक ऐसी जगह होती है जहां पर कोई ना कोई ऑब्स्ट्रक्शन है, पर क्योंकि एक स्पर्म की बनावट, स्पर्म की मैन्युफैक्चरिंग इज गुड, so we are able to get sperms easily. Now, the other is non-obstructive azoospermia. Now, non-obstructive azoospermia means that the testes has an impaired spermatogenesis. Testes का sperm बनाने का तरीका is poor. And this is because of testicular dysfunction. 60% of the cases are like this. And this is what needs to be actually treated by micro-TSA. Now, let me be very, very clear with you. A very large number of patients fall in the purview of a central area. You cannot diagnose them for sure whether they are obstructive azoospermia or non-obstructive azoospermia. A lot of people are in the midline. So this judgment needs to be done on table at the time when you are operating. I'll also give you another important thing for you to understand, that people with cryptozoospermia, या जिनके sperms बहुत कम हैं, ना के बराबर हैं, गिनती के sperms हैं, and these sperms are not good in quality. In these patients, when doing ICSI, the best sperm is a testicular sperm. A lot of literature is there on this. There is a major study of Steve's, and this major study shows clearly that a testicular sperm is better in very, very low sperm count. So this becomes another indication to operate on these people. Now, let me talk about the pathophysiology of non-obstructive azoospermia. So obstructive, we have understood that obstructive could be in the vas, it could be in the epididymis, it could be in the prostatic area, could be in the seminal vesicle area. But non-obstructive azoospermia is something very interesting which we need to understand. So it can be either primary testicular failure, which includes genetic disorders like Klinefelter syndrome, Y chromosome microdeletion, cryptozoospermia, varicocele, idiopathic cases. Or it can be secondary, which is hormonal imbalances, gonadotrophic exposures or systemic disease, or a mixed pattern, which nowadays I'm finding very, very common, where there are different areas of the testes which have a different function. तो देखिए, अगर आप इसको गौर से देखें, समझें, तो आप ये रियलाइज करेंगे कि Klinefelter syndrome is not as uncommon as you think. In fact, Klinefelter syndrome is a very common thing happening. So these patients of non-obstructive azoospermia need to be diagnosed as the cause. देखिए, एक चीज बहुत simple है. I always say, whenever there is a patient of azoospermia, you need to diagnose the cause of azoospermia. And once you have found the cause of azoospermia, you will know what exactly you need to do. So there are three types of azoospermia. Number one is pretesticular. Pretesticular means कि आपकी testis से पहले brain से hormones कम बन रहे हैं. So hypogonadotrophic hypogonadism. In hypogonadotrophic hypogonadism, the best way to treat this patient is with HCG and HMG. This normally we would give to patients who do not have sperms and low FSH and low LH. So the first baby which we gave of hypogonadotrophic hypogonadism is a very interesting story. So this lady came to me, very rich lady, and I had known her for a long time. So she came to me and she said that I know somebody who has this report, showed me zero sperm, then showed me a low FSH, low LH, and said this is the other report. And this was diagnosed when he was 15 or 16. अब शादी हो गई है, शादी होने के बाद में 2 साल हो गए हैं. So I just looked at her and said, what do you want? She said, I want to buy the most expensive sperm in the world. I looked at her and said, कि सबसे expensive तो मुझे पता नहीं, पर सबसे valuable sperm आप ही के बेटे का अगर मिल जाए तो क्या होगा? Because I knew, she told me later that it's her son. After some time she told me. So we gave him HCG, and after giving me HCG, we had testosterone come back. We started HMG. And after about 4 months, when he gave another semen sample, I got a call from my lab. My embryologist, I love him, you know, he's such a darling. And he said, sir, sperm dikh gaye. I said, wow. We did an ICSI, first cycle did not get pregnant. Second cycle got pregnant. Finally had 2 beautiful baby girls. I think they're 15 years now. I think 15 or 16, something around that. And, but there was a big problem. And the biggest problem was, she said, you've given me 2 girls. Is there any way I could have got something else? So I told her, this is something which can never be done, will never be done, and is not possible. So if you go into this story, you'll realize that from that time till now, hypogonadrophic hypogonadism के अनगिनत बच्चे हम पैदा कर चुके हैं. और पता है सबसे अच्छी बात क्या होती है? At times, you can actually get very good sperms because hormone ही तो नहीं मिल रहा है. That testes is waiting to be started. Next comes obstructive azoospermia, which I told you about. In this obstruction, you can get sperms, and these sperms from the epididymis can be as good as an ejaculated sperm. And third, of course, in non-obstructive azoospermia. So now, how and what do you do to examine this patient? Now, any patient who comes to you with azoospermia, you have to see the secondary sexual characteristics. आपको देखना है उनके characteristics कैसे हैं, are hair there or not, what is the body, what is the way the chest is. You need to see testicular volume. See, normal testicular volume is about 20 cc, and the largest diameter in the testes should be at least 4 centimeters. If it is less than that, then it's a smaller testes. So smaller testes will probably be non-obstructive azoospermia. Then you have to palpate the vas and the epididymis. This needs to be done to see if there is any kind of the absence of vas, which happens in cystic fibrosis. You've got to examine the patient and see the varicocele. Now, varicocele assessment becomes very important, and let me be very clear with you. The best way to assess varicocele is manually with your hands. Ultrasound just gives a confirmation. So I would like all of you to get a patient examined. So बहुत बार आपकी clinic में होता है that you can't examine. So you should have somebody who can examine this patient, because an ultrasound cannot replace an examination. And then after that, the next thing is a digital rectal examination. So all these examinations need to be done in any case of azoospermia. 5 चीज एग्जामिन करनी है: secondary sexual characters, testicular volume, palpation करना है, varicocele देखना है, और digital rectal examination करना है. Now, laboratory investigations. What investigations do you need to get done? FSH, LH, testosterone, inhibin B people get it done. I don't get it done a lot of times. And prolactin and estradiol if needed, if the weight is more of the patient. You need to get this hormonal investigations. 5 investigations, 5 things to palpate, 5 things for hormonal investigation, and 2 genetic testings. One is karyotyping. Now, in karyotyping, what you actually get done is, when will you get a karyotyping done? So you are going to get a karyotyping done. You will get a karyotyping done when the man is azoospermic or his sperm count is less than 5 million, when the FSH is raised and the testes is small or small. And a Y chromosome microdeletion you will get done when the sperm count is less than 1 million, when there is an elevated FSH level, and when the testicular size is small. So any of these things which are there, you are going to get a genetic testing done. Now, let me go on to the next slide. What will you see in the semen apart from azoospermia? 3 things. You will see in the semen, number 1, ejaculate volume. Now, the volume should be at least more than 1.5 ml. If it is less, there could be an obstruction. You would like to see the pH. pH normally is 7.2 to 8. And in case there is azoospermia, you would also, an ejaculation as well, you would like to see a post-ejaculatory urine analysis. Now, today morning I got a patient who said he'd come from Bihar. So he had come, examined him, said, I'm an ejaculation I have. I examined him, planned a urine analysis for him. Now, if I find sperms in them, I would know that sperms are being made, and then I could plan what needs to be done. So it's very important for us to understand these 3 things in this whole process. Now, how do you differentiate obstructive azoospermia from non-obstructive azoospermia? So, testicular volume of non-obstructive azoospermia is smaller, FSH level is higher, ejaculation may be reduced, not necessarily, testicular consistency may be normal, and the success rate is very good to get sperms, about 90%. While in non-obstructive azoospermia, you could get a success rate of up to 50%. Now let us understand another small thing. Most of the patients we get are non-obstructive azoospermia. And the second thing is, a lot of people lie in the mid. A lot of patients of FSH normal also turn out to be non-obstructive azoospermia. So this judgment has to be done clinically with hormones, but the final judgment normally is done when you open up the testes. Now, what are the surgical managements, the evolution of the techniques? So this is very interesting. I'm coming into the techniques now. And if I look into the evolution took place in the era 1990s. So in 1990s, something which was interesting was that you had in the 1990s you had testicular sperm aspiration. So what you did is you put in a needle to get sperms. पर बड़ी interesting बात आप अब ये समझ लो आप. ICSI आया 1992 में. In those days there was no ICSI in India, and at that time sperm retrieval was done by Professor Kaza. And at that time, he used to open up the testes under a microscope to find sperms. So he was ahead of his times. During 1990s, it used to be a TISA or a small testicular biopsies. In 1999, Peter Schlegel did the first micro-TISA, where he opened up the testes microsurgically. Then the third era, which will be coming in the future, is going to be the era of artificial intelligence and novel visualization techniques. Please understand. Today, micro-TISA is the standard, the gold standard to get sperms. The sperm retrieval is much more. But in the future, there are going to be a few things which will help get even better sperms and more sperms, which I'll show further on in the slides to you. So let's go on to the next slide, and let me now go on to the conventional techniques. So the conventional technique, which is very common, is what we know as a PISA. So PISA is when we put in a needle into the epididymis, make a suction, take out the sperm which is there, place it, use it to give an ICSI. This is PISA, percutaneous. And up to 90% success is there in getting sperms. But there is, I'll tell you after showing this video, let me show you this video first. So what we do in a PISA? So in a PISA, we take a butterfly, hold the epididymis between the fingers, the thickest place we can hold. We place the needle inside it. There is a 10 ml syringe which is there at the end, in which suction is given. And giving this suction, we are able to pull and clamp it so that we may get some liquid outside the epididymis. Now, once we have taken this, in this we are going to examine and see if any sperms are present. Now, what is the advantage of a PISA? The advantage of a PISA is कि इसके अंदर हमें 80 to 90% sperms मिल जाते हैं, लेकिन इसके लिए full epididymis चाहिए. And the second advantage we have is it is minimal invasive. You can do it under local anesthesia. But the interesting thing about PISA is that at times the sperm retrieval and the number of retrieval is less. So what we normally do is a microsurgical epididymal sperm aspiration, MISA. In MISA, we open up the epididymis, put a catheter into it, take a lot of material and freeze all these sperms apart from the sperm which we have taken up. So a MISA is better in terms of the number of sperms you can get because you microsurgically are opening up, पर इसके लिए general anesthesia देना पड़ता है. That is one area which is different. Now I will tell you to the next technique, which is a TISA. TISA is when you put in a needle into the testes, minimal invasive, local anesthesia needed. You can do it very, very simply, but the limitation is in non-obstructive azoospermia, it's very difficult to get sperms. But in those patients of obstructive azoospermia, in whom you have not got sperms from a PISA, you may get some sperms by TISA. TISA is when we put in a needle, just a needle. So TISA per se is not very helpful. About this, we need to be very clear. Now, the third technique is conventional TISA. So what happened? People used to take a testicular biopsy, and the surgical approach was that you could open up the area. You could take a surgical biopsy, use this biopsy, and the tissue requirement which would be there would normally be taken from only one area. It would be used, but the complications normally were very less. पर इसके अंदर करीब सिर्फ 20 to 30% sperm मिलता है, and this is a procedure in which sperms will be only got from one area. What I mean to say is sperms will only be got from one area. So let me show you the video of this. So if you see over here, a small opening is made, and in this small opening, you make an area from which you take a little bit of material. You put this material onto a center well and you take it. So conventional TSA is normally not done per se in any non-obstructive azoospermia. It can be done in an obstructive azoospermia. Now the third gold standard which is there is microtesticular sperm extraction. So now I'm going to tell you a lot of things about it. I will tell you how micro-TSA represents the gold standard of surgical sperm retrieval by utilizing a high magnification of 15 to 25x. I normally work on 25x. We've got to identify the optimal seminiferous tubules. जब हम खोलते हैं टेस्टिस को तो उसके अंदर हमें larger tubule, opaque tubule, अच्छे tubule ढूंढ के निकालने हैं. When we do this, we have minimized tissue trauma because we take out very little tissue. When we take out very little tissue, we preserve the testicular architecture because we preserve the blood supply and we optimize the sample quality. See, what happens is we normally take out very small bits of seminiferous tubules from different places. बहुत अलग-अलग जगह से we take out small seminiferous tubules. Now these small seminiferous tubules, because we take them out from different areas, the chances of getting sperms are more because we see with our own eyes the seminiferous tubules, we know the area to take it out from. And since the quantity is less, testosterone goes down less. This is very important. Now, let me also now go on to the next thing. Now, that what is the main takeaway of micro-TSA? So micro-TSA live birth is higher. A systematic review clearly shows it is the best approach. Now, I'm going to show you stepwise laboratory protocol. Everything I will show you today in this video. Today, we are able to get sperms in 50 to 70% of patients and live births exceeding 40%. But this has been after doing this work for over 20 years. So today in this video, I am going to bring to you everything which I do, which I've learned in the last 20 years. What do I do in the theater? What do we do in the laboratory? What does our embryologist do? Everything from beginning to end, and how do we follow up the patient? So the first thing which I'm going to bring to you now is the pre-operative optimization. तो किसी भी पेशेंट को अगर हम लेके आ रहे हैं सर्जरी के लिए, we need to optimize it, and to optimize it we have to confirm what is the status. There should be a centrifuge semen sample which tells us. We need to do a genetic and diagnostic workup, karyotyping and Y chromosome microdeletion and endocrine profiling, and at times a scrotal ultrasound, so that we are very, very clear what we are going into. Third is, in case the testosterone is down, we would normally give these patients HCG or we'll give these patients clomiphene so that the testosterone becomes normal. Why? Simple. For sperms to be manufactured, the intratesticular testosterone should be good. अंदर से टेस्टिस टेस्टोस्टेरोन से ना ही होनी चाहिए, तभी जाके स्पर्म बनेंगे. And this is the reason we need to increase the testosterone. And we also at times consider FNA mapping. Now, FNA mapping is very interesting. I'll show you. It's also known as different procedures, but prior to micro TC in a lot of patients, I would do an FNA mapping. So let me show you what an FNA mapping looks like. So in an FNA mapping, we normally mark out 16 areas in the testes. How many areas? 16 areas. So what normally we would do is, we would open up, we would know 8 are above the equator, 8 below the equator. Now we put in a needle with a 10 or 20 ml syringe, just like we would put in a TISA. We are going to now give pressure, pull the needle out, we get some tissue, but some tubules also come out. Now these are the tubules which we normally are going to hold, and with a microforceps go on taking out this tubule till the time we get some tissue. Now taking out this tissue becomes extremely helpful for us. Why? Because we get a reasonable chunk of the tissue. Then we pick this up, send it to the embryologist. In case sperms are there, then we know in case they are enough, fine. If they are not enough, then we need to open up the testes in this area. So this is FNA mapping. Now next, I'm going to come on to what is the surgical setup which we normally will have. So normally the surgical setup we will have is the anesthesia and temperature. So we've got to maintain a temperature of 37 degrees. So it should be a warm room. If you see over here, all our equipment in which we are going to take in the sperm is maintained at 37 degrees. And we need to preserve the spermatogenic cell viability. So I'll just show you what we exactly do. So what we do is we use the same warmer which we use for our test tubes. We have center wells on this which are placed with media in the same temperature which we would use. Now, this is what we would normally do with the opening up. So we open up midline, because in this area, the vascular area is the least. So least bleeding takes place. So we open up the testes in the midline. This is what we normally would be doing. Now, the exposure needs to be good. And after opening in the midline, when we open up the testes, I'll come to the next stage. Now, in the next stage, what I normally do is I have a small micro ultrasound. So I use this ultrasound on the testes to see if there are any vessels, because now the incision which I would give will be the transverse incision. Now, this transverse incision is an incision which would be given by me after an ultrasound. So the chances of bleeding are very less. And what I use is an operating microscope, 15 to 25x. I normally operate on 25 for a micro TSA, and use a micro Doppler with it wherever it is needed. It gives me a better retrieval, and it gives me a faster closure. I'm able to do it faster. So I'll just show you this. So if you see over here, this is how a micro Doppler will be used on the testes to judge an area where there are no vessels, so that we could open up, because we really, honestly speaking, do not want much bleeding. Very little bleeding is what we really want in this. And let me show you, this is a 25x, what we do as a microscope. And this is what we normally are going to use over here. So let me go on to the next slide. Now, how do we do the tissue extraction? So in the tissue extraction, what we normally would do is, our search strategy is very simple. We do a sweep from superficial to deep poles and excise only dilated opaque tubules. Now, when we do this, there is a 70-fold less tissue excised than if you do a normal sperm retrieval by opening up multiple biopsies. And the tissue quantity is only 10 to 20 milligram per side. And we stop the moment we get motile sperms. So what happens is that the testosterone, even if it goes down, recovers within 6 months. So let me show you exactly how we do it. So what we do over here is we have opened the testes. You can see this is the primary opening up of the testes. And when we're seeing into the microscope, you see this whole area. We start observing from one end. And when we observe from one end and go ahead, this is the way we normally see it. And just see the tissue. It's very little tissue which we actually take out from the testes in these patients. Now intraoperative decision making, how do we make it? Now, in the intraoperative decision making, the importance is of two things, unilateral or bilateral. So what, see, I today have done about, every month I do about a dozen of cases, more than that, in fact. So over a period of time, my speed has increased, the way my eyes pick up has increased, because this is a job of two things, patience and patience. So you need patience and you need patience. So now I'm very, very clear that if I have not got something in half an hour in a testes, I move on to the other testes. But earlier, I used to spend more time trying to get a sperm. But ultimately, the moment you get a sperm is the time when you would call it off. Or you come to know, for me, half an hour this testes, half an hour that testes, if I don't find. I probably would get 15 minutes more, but by that time I would have sweep the whole testes. And that's important. And the second important thing, apart from the this thing, is the intraoperative biologist. So what I normally do is I take a continuous feedback from my embryologist. So we have two tables. So we may have two people working at a time. So what I do is, with one main person, I have a video call open. I'll just show you what I do. So it's you could say a small trick or a jugaad. So the camera is held normally there. And I would normally be talking after sending, have you found, have you not found? I have found, please send me some more tissue from this area. Please send me some from the area which was before. And these are very, very helpful tips to us. So now let me show you how we do a micro-TC. So let's see this video. So what happens in micro-TC? In micro-TC, we open up the testes. And after opening up the testes, we observe under a microscope. So this is the first layer where we're picking up different areas, taking these areas and taking these tissue pieces. After seeing this whole area, this is the first layer. So I told you we open up in layers. So I'm opening up in the first layer. This is what exactly is the procedure of micro-TC. We would pick it up, send small areas for testing further. So this is what a micro-TC would look in. Now I'll show you the microscopic view, the way it looks. Next slide. So this is a microscopic recording. If you can see over here, very, very clearly, all these are flat areas. But this is an area on where you can find a dilated tubule. So this is the dilated tubule which you're going to pick up under a microscope. Now this was a patient which I remember distinctly had a late maturation arrest. So this is the picture which looks like in a late maturation arrest. So you'll pick up tubules after scanning everything. So I had opened up the testes, was scanning. These were the tubules which we found over there and took them. You can see over here. This is an area which is going to have dilated tubules. Now under a microscope, you're seeing this, it appears to be large, but it's a very, very small, tiny piece. Very small, tiny piece. Now these would be processed in the laboratory to find out sperms. अब इनको खोल के हम देखेंगे कि sperms इनमें मौजूद हैं या नहीं हैं. Now, let me also show you another slide of a patient of hypospermatogenesis. So just see over here, you can see this dilated tubule. आप देख रहे हैं बाकी सब पटके हुए से लग रहे हैं. This appears to be kind of opaque, slightly yellow, dilated, which is going to have a dilated seminiferous tubule, which we are going to take out over here. You can see over here, none of these except for this area would have a tubule, which we again taking out to be tested. Now the trick is to be able to identify them, which can only come with practice. And the fact that you continuously need to be in touch with your embryologist, who needs to keep on telling you where they have found sperms, because then your mind knows this is an area which I need to see. Just see over here. So this was hypospermatogenesis. The earlier was a late maturation arrest. Now let me go on to show you how much the advantage is there. So if you see the first, it's a micro T-cell specimen. It's a T-cell specimen. You can see the amount of tissue which is taken out. Now what we do with this tissue of a T-cell tissue is normally we would slice it, cut it, which will normally done with 2 needles, so as to open and chop open every piece like this. Just pulverize it. And you can see very clearly in a T-cell sample, we are pulverizing it to make it like this when we are going to take it under a microscope. So when we take this under a microscope, this is how it appears to be. And when we see this under a microscope, we're going to find sperms in this. Now let me show you a micro T-cell sample. So this is a sample which we have. We are cutting and mincing this sample. We chopping it off slowly, doing it to a level that we have very small areas. Now this is what we're going to pulverize, chop off, so that these may open up and sperms may come out. And these are the sperms. This is how it looks. Now this is what we are going to take to the microscope. And under a microscope, we're going to observe. And this is when we are going to find sperms in this and use those sperms. Now comes a T-cell sample. T-cell sample I showed you, micro T-cell sample was a very little bit of tissue. Now I'll show you what we do with a micro T-cell sample. I've shown you a T-cell sample earlier. So in a micro T-cell sample, what we need to do is immediate handling. In a T-cell sample, we have taken it out and big piece we have sent, we have closed. But over here, we need immediate handling and we need temperature control, which needs to be taken as I had told you. We need a 37-degree Hippies buffered medium with 5% albumin within 5 minutes to avoid cold shock. And we do mechanical mincing under a stereozoom microscope using very fine needles until no intact tubule is present. And we express all this fluid into a 10 microliter droplet and scan for 30 minutes at 200 to 400x. Now let me show how we do it in our lab. So what we do over here is, you can see over here, we have taken this specimen and it's a very different specimen from a T-cell sample. So what we do over here, we just cut all that specimen with a needle so as to take out whatever is there inside it, literally pulverize it. And after we have done that, we would take out, and this is another thing which we normally do with the syringe end, so that we could squeeze out every sperm which may be present in this particular tissue. Once this is done, then we are clear we need to take it into a microscope, under a microscope. So Now what happens is, you've seen under a microscope, you have not found. What is the next step which you could do? So in the next step, what you could do is, you could centrifuge the residue. And after centrifuging the residue, you could give it enzymatic treatment. So what we normally do is, we give them collagenase 4 treatment, and we prepare this 1000 international units, and with DNase 25 microliter per ml. And this we do in Hippies medium and gently agitate for 30 to 60 minutes. Then we dilute, centrifuge, and see again and re-examine. And believe me, we get a lot of sperms in those specimens in which we have not got with mechanical mincing. So there is a lot of work which goes into it, not only in the surgeon's hand, but also the embryologist's hand. तो आप ये समझिए, there is a testis which has focal spermatogenesis कहीं कहीं हो रही है. आपने पूरी टेस्टिस खोली, आपने माइक्रोस्कोप के नीचे पूरी टेस्टिस में ढूंढा. If there is a seminiferous tubule which appears to be having sperms, you take out those seminiferous tubules. All these seminiferous tubules are chopped, squeezed. You examine if there is a sperm, pick out the sperm. If it is not there, you do enzymatic digestion, and you then again look for a sperm. And if you find a sperm, then this is where you would go and ICSI. And in this ICSI, there is one thing very clearly: if there is blood contamination, it's fine, because that helps us in finding a sperm. I'll show you how for us. I mean, a lot of people use an erythrocyte buffer, but this is what we do. I'll just show you now. See, so what we do over here is, if you can see over here, we're doing an ICSI. We're trying to find a sperm, and the sperm is not found anywhere. Now, soon you will see one sperm, and you can see it against a background of RBCs. The RBCs are all these red blood cells, and you are going to find one sperm, and you slowly will pull that sperm out. Take that sperm in the needle, hold the egg with the other pipette, inject the egg, take a little bit of cytoplasm, and place the sperm back into the cytoplasm. So an ICSI has been done with the sperm of a man. So there is a lot of work which goes into it. This is a lot of work and a dedicated work around the table of an andrologist, of an embryologist, of an endocrinologist, of the reproductive endocrinologist. But you know, it doesn't end over here. This is what I'm trying to tell you. Now, in case you get sperms which are less, cryopreservation of these special sperms is important. So you could do it normal cryopreservation, or you could do a vitrification. And in vitrification, in these samples, you can get up to 60% post-thaw motility. So therefore, you can vitrify them in small aliquots. And this is something which has been very helpful to us, vitrification. Now, predictors and decision support. Now, this is most important. Every doctor who's listening to me now has to take a slide of this, a picture of this, which they can use. I do all this because I really want you to understand that helping our own patients is most important. So just understand, in case there is a histology of late maturation arrest of spermatogenesis, the chances are that you may get up to, in hypospermatogenesis, up to 70%, 80%, in maturation about 40%, and Sertoli only 20%. The testicular volume, if it is more than 8 ml, it is significant of getting a more sperm retrieval rate. FSH isolated will not happen. You have to combine it with everything. But in case the FSH is high, there is a chance of derm cell dysplasia, and sperm retrieval rate goes down. The maximum which I have till date been able to get sperms in, it was 115 FSH. I got sperms in this patient. Now, a positive FNA mapping helps you in getting sperms, and the surgeon and center volume. See, this is um, it's the man behind the machine over here. So the learning curve is high, at least 50 cases, and any high volumes center should have a sperm retrieval rate of about 50%. So any complex case you have needs to be ideally referred if they want to have their own baby. Now, post-operative management is 24 hours. You have to give scrotal support. Few people give ice packs, I don't. After 7 days, you still continue the scrotal support. It normally heals well. 3 months, measure testosterone if you need to. Give HCG if the patient wants. 9 to 12 months, normally the patient has recovered completely. And if a re-micro-TCA needs to be done, then an FNA needs to be done before entry. So if I put it all together, till 3 months, hormonal optimization, day 0, microsurgical extraction, 0 to 30 minutes, one size, and after it has come out, 0 to 30 minutes, mechanical mincing, 30 to 90 minutes, collagenase digestion, same day, vitrify surplus. After 1 week, review wound, can go back to work. After 3 months, if you need, test testosterone, and this person, if there is low, may be treated, but normally in micro-TCA, the testosterone does not go down. Now, future refinement under studies which are there in the field of micro-TCA, in the future, a lot of cutting-edge technologies are going to come, have come. One is a multi-photon microscopy. So you integrate a operating microscope with real-time tissue analysis. It differentiates the spermatogenic from Sertoli cells only, and it does it because of its intrinsic autofluorescence. So precision would be there, and it will raise the sperm retrieval rate without extra tissue removal. So this is the first thing which is going to come in the world, or it is being used, and it's in experimental stages. This is something beautiful which will come out. Intraoperative analysis could be done by AI imaging, which will be better, faster. Laboratory enhancement can be done by automated analysis of the specimen, and detection accuracy may increase. Now, see, one thing is very simple, that you could get a pregnancy from 25 to 45% in them. You could get 20 to 35% live birth rate. Cumulative success rate after 3 cycles in patients like this could be 50 to 70%. No significant birth rate increase if it is present. It is because of the innate genetic problem which the man has. Genetic abnormality inheritance risk is based on the parental factor, and normal childhood has been seen, and long-term development risks are not of major significance. In the conclusion, there is a 1.5 times improvement, 60 to 70% complication reduction, and 50 to 70% cumulative birth rate. One thing needs to be done: diagnostic protocols used to be used, treatment and algorithms need to be used, outcome monitoring has been, and quality standards. What is the verdict? The verdict is very simple. It is just excellence for the patient, and rigorous training can be done for this. If you can have 70% retrieval rate, live birth rate, and very little complications, it is great. Why? Do you know why I say this? I say this because man is very sensitive. Man doesn't want his testes to be operated. And if it is operated, you need to be very sensitive to his sensitivity. And it has to be gently. One. Number two, we ultimately are in the larger picture of work, which is trying to relieve the pain which people have. The biggest blessing which all of us could have on earth is trying to relieve our fellow human beings, and we are blessed as doctors, as gynecologists, IVF specialists, to relieve that pain and stand with them when they are most vulnerable. Azoospermia is something which is very painful to a man, psychologically, emotionally, physically, and even in a relationship. For him to have his own child is priceless. And I'm sure, after seeing this, you would realize that 70% of azoospermic men can have their own babies. At this ISAR meeting where I'm addressing, first of all, let me be very, very thankful to all the office bearers, all the doctors who invited me, the president, vice president, the organizers over here, who are brilliant, who speak to me so sweetly and have invited me here. But most importantly, जो जज्बा आप में है कुछ वाकई में करने का हर डॉक्टर के लिए कि वो सीखे, अपने एरिया में करे और इस पेन पॉइंट को हर इंसान का कम हो। कहानी अपनी नहीं है, कहानी उन पेशेंट्स की है जिनको इसकी ज़रूरत है, is brilliant. Thank you very much once again, everybody at ISAR, everybody who's joined here. I'm extremely thankful to you because your giving me this time gives me an opportunity to tell you where the world is going.
What to chairpersons? Govi sir,
Thank you so much, Dr. Sunil. As usual, um, when you talk, we all get, I get hooked to it because you explain it so nicely. So, do we have any questions?
Govi sir.
Sunil, I'm Govinath here. Can you hear me?
Yeah, I can.
Remember, we met in Ahmedabad last year, at conference.
Yes.
You
Hello?
forgot, eh? We
No.
met together on
No,
one talk.
I can't see you at the moment.
Yeah. Okay. I don't know.
Yeah, please.
Yes, we can see you, sir.
Yeah.
We met last year in Ahmedabad. That
Yes, sir. Right, sir. Of course, sir. Now I can see you. Yes, sir. Such a pleasure to hear you, sir.
It was really wonderful because you have been always wonderful as an andrologist. We used to meet in andrology workshops most of the time. Is it not? From 25 years, more than 25 years.
Correct, sir. And I've always missed you nowadays. Nowadays, I always miss you. And I remember that the conference which you had in Simar, the ISAR conference initially, in your beautiful hospital next to a river. I can never forget it, sir. And you were so warm, so affectionate.
You have come, yeah, sure. Now, see, only thing, one or two questions is that, do you believe in varicocele repair in azoospermia?
Sir, very simple. Any person who has azoospermia, non-obstructive azoospermia, in whom I find that I would say the hormonal optimization is not happening and the FSH and testosterone are close to the optimal, a bit raised, but close to an optimal. And the age of the wife is not too much that I can wait for 3 months. I would probably do a microsurgical varicocelectomy and then take this patient up for a micro TCA. I normally take at times 2 to 3 months to optimize these patients. So I'm very particular about a few things. Number one, trying to get the testosterone up. And the second important thing which happens is
Treatment
that,
before
sir,
microTISA, is it not? That
sir,
is treatment before microTISA.
yeah, not all patients, but a few patients definitely, because it also affects in case I get a few sperms, then the DNA fragmentation of these sperms may be better after a varicocelectomy. So I discuss with the patient and I see the age of the woman, I see the hormonal status of the patient and take a call if he can wait for 3 months.
What about otherwise? There is normal little sperms will start coming with the varicocele repair because
There is, yes, it's a very nice thing which a very well-read man can say this really. There are a few studies in which in non-obstructive azoospermia, after doing a varicocele repair, microsurgical, they have also found sperms, which is correct.
But no. See, somehow I'm not very convinced about that because we never had any opportunity to see a patient with sperms. Once really it is azoospermic, is it not?
Sir, I have seen so many patients in whom I'm not talking of azoospermic patients, but I'm talking of patients who have severe oligospermia, in whom I've done a varicocele repair, and in whom the count has become so good that they actually, instead of an ICSI, got a baby with an IUI. And it's not one patient, I have a couple of patients. And more than that, you know what happens, sir? Because of a varicocele repair, the quality of the sperm goes up.
And that's why mainly it is causing DNA fragmentation. That's what they are telling.
The quality of the semen goes up. So in cases which I think would be the best, and if I've counseled the patient, if the patient can wait, a lot of patients can't wait. I mean, they've been married for 10 years, but when they come to me, they say, just get it done right away. I wonder, 10 saal se tum ruke hue, why are you doing like that? But yes, this is what happens, sir.
But about other pre-treatments like gonadotrophins?
I always pre-treat patients, sir. I always pre-treat patients who have a low testosterone. So I have a protocol for that. In case the patient has a low testosterone, I could put them onto HCG. But in case I find that the FSH and LH level are not too high in patients, I can even put them onto clomiphene. These are those patients which I would put. And I find that normally once the testosterone has come above, say, at times these patients I get with testosterone 55, 65, I get a lot of Klinefelter syndrome, sir, low. So normally I try to get the testosterone up and then I do a micro TSA for these patients.
No, but it is there. Everybody claims like that. But how can you really say that it is because of your treatment? You get extra recovery of the sperms. That's my...
Sir, literature says it, number one, I follow it. Number two, I get a lot of Klinefelter and bad cases. I get small testes, I get FSH. The maximum which I have recovered till now, I think it is 118, 18 or 1, I think it was 118 FSH. I got sperms. But these were those patients in whom I had actually optimized them for some time.
No, that's right. But see, really, if you want to say it is because of your treatment.
No, I'm not saying because of my treatment. I'm saying if I have to go into a battle, I've got to be prepared for it.
No, just because it is very difficult. What about the repeat micro TSA?
I normally don't do a repeat micro TSA because these patients don't come back. Number one. Number two, what literature says is that if you need to do a repeat micro TSA, it should not be before 9 months. And when the testosterone has come back. That's what literature says. I must have done about 2 or 3 repeat micro TSAs only, sir.
Okay.
And thank you very much for asking these pertinent questions, sir. I always admire you. There is no doubt about it, sir.
Sir, is there a role of any pre-treatment with antioxidants?
Yes, of course. Antioxidants.
Do you do that?
I give antioxidants always. See, let's understand, if you have read the MOSI paper, which I'll send to you, the MOSI paper is very simple, that most of the idiopathic azoospermia, oligospermia, idiopathic infertility of the male, even with a normal count, is because of oxidative stress. And these sperms, as it is, have been in oxidative stress. In fact, I had this patient who was absolutely necrospermia. By necrospermia, I mean there was no motility, there was nothing in the Horst test. And in these patients, if you keep them on antioxidants for 3 months, 4 months, 5 months, and do an Horst test again, there is a chance of getting motility in a few sperms. So I always put them on antioxidants as well. Correct.
What about giving a pre-treatment with antibiotics or probiotics? Do you do that, or do you directly?
No, I don't. If there is
Or
no
do you give a pre-op one shot of IV, any antibiotic? I mean, as a routine, what we do.
No, as a routine, I always get a seminal culture done. If the seminal culture is fine and he has no infection, then I give no antibiotic at all. And I only give a a pre-surgery shot like I would give in
Pre-surgery shot.
like I would give in any surgery.
Any further questions?
There is one question by Radha Madam. Radha Madam is there?
I had seen her. She was there in the panel.
I'm here, sir.
Can you ask that question?
Yes, I just wanted to know, do you do 17 OHP in these patients before you start? Because you are talking about the intratesticular testosterone levels. So would you, based on the 17 OHP, do you counsel them whether they respond to the treatment?
No, I don't.
Okay, so we have started doing this, but still we have to analyze our results as a part of a research project. We are doing 17 OHP for these patients, all the patients, before we start the medical treatment. So there are few papers which measure the 17 OHP and it helps in counseling the patients. That's why I thought I should. Yes.
No,
Can I ask one question regarding the whether when will you decide whether you will go for a trial PISA for all the patients or directly go post for PISA during IVF routinely?
I don't go in for any trial. I explain the patient very simply, and my counseling takes about 5 to 10 minutes of mine. I tell them that I plan to go into the theater, even for an obstructive azoospermia, because a lot of patients actually come into a system of this way or that way, I mean, in the mids. So the FSH would be normal, the testicular size would be normal, but you'll realize that their epididymis is empty. Uh, So in these patients, I always counsel my patients that I'm going to take you into the theater, and on the table we'll plan whether we get sperms via needle. Non-obstructive azoospermia patients, of course, I tell them from the very beginning that I may need to do a micro TSA, one side and both sides. And in fact, if I don't get sperms on one side, I always open up the second side. I don't wait for another time to try the second side, and I don't normally do a trial.
So one question, do you do it on the day of retrieval or a day prior and then freeze it?
No, I don't. I do it on the day of retrieval. I do the micro TSA 4 hours before or 3 hours before. And that's what I do. Because see, what happens is the moment you get a, now I'll just tell you the way it is done. The moment you get a specimen, you've got to tease it. When you get it, you do not find any sperms in it in half an hour, 45 minutes. You absolutely go into the collagenase DNAs. After that, it takes about 90 minutes. So what you're going to do at that time is that you may need to at that time incubate the specimen. Now this incubation may help in our finding out the sperm. So once I get the sperms, I would then take them out and after retrieval do an ICSI for them.
There are some studies of overnight incubation or more than 2 hours.
They do it, but what I've realized is that this is doing good for me. I get good results in this, and my sperm, finding out the sperms is good. But yes, some people do overnight incubation. I don't know, some also do overnight, some also incubate the eggs for long. A few people are there who don't do an ICSI within 6 hours of taking out the eggs. But well, I definitely take them out about 3 or 4 hours before going in for the retrieval. In non-obstructive azoospermias, I explain every patient that the best thing which I could do for you probably is do a ICSI and fresh retrieval. You'll be surprised to know most of the places in the United States cannot do it fresh because OT time they don't get together. The andrology lab, the andrology surgery is different. It's a different place. Their IVF OTs is in a different place. So most of these people actually do surgery, freeze sperms, use their frozen sperms. But another big problem which happens is there is a 50% loss of sperm. And these are very precious sperms. At times, all that you get is 5 to 6 sperms. So you can't lose them. So you need a fresh sperm. Freezing them would actually lead to loss when we thaw them.
Any other questions?
Plus, when the number is so low, you can't even retrieve them. I mean, after thawing,
Yeah, that's
when
what
the
they say.
number is so low,
Post-thaw recovery is less.
yeah,
So
the
it is
post-thaw recovery will not be there. So, yeah, it has to be fresh.
we are very
But, sir,
lucky.
one question is what I want to ask is that since you have this setup of micro-TSA, but a lot of people in districts and they don't have this setup. So, do you have any message for them that like they can only probably do a PISA or a TISA or a TSA?
Now,
They'll
yeah,
stop at that. They
no.
won't do.
See,
Yeah.
I'll have a,
They don't have the setup for
Doc-
micro-TSA
Dr.
microscopes.
Anuradha, thank you for asking me this question. I say this why? Because I'm saying it honestly the way I believe it. I get lots of patients from outside And what happens is in a non-obstructive azoospermia, I'll go step by step. Number one, to do a micro TSA, it is not the microscope, it is the surgeon, it is the embryologist, it is the laboratory work, it is the cryopreservation, it is the care which you have to take of the patient before taking for a micro TSA and after you have done a micro TSA. So it actually becomes a whole long story. So a lot of people do not have it to do a micro TSA. What I believe is if there's an obstructive azoospermia, which you feel is an obstructive azoospermia, please go ahead and do a PISA. In
Yes,
case you
Dr.
do
Kedar.
not get a sperm in a
Again.
PISA, it could be somewhere midway, which you could send to somewhere. For a non-obstructive azoospermia,
I'll
it's a
yes.
very small request. Don't put in a needle into the epididymis because the epididymis, the moment you put in a needle,
I'll
the
stop.
integrity is broken. And in case, I'll give you an example. In
Don't.
case this patient is in a situation that post varicocelectomy, he could make sperms, he will never get sperms because the integrity gets broken the moment you put in a needle. So any patient with non-obstructive azoospermia is preferably referred. And it is honestly important for this patient who's come for his own sperm that he should be referred.
No, Dr. Kedar, please. Dr. Kedar, please.
Dr. Anu?
Dr. Kedar, please. Just Dr. Kedar.
Dr. Anu, please mute yourself. Okay, sir, I mean, the story which goes in the
Dr. Anuradha,
periphery.
Uh,
Yeah.
should we
Are we,
start
are
with
we done? Are we
next
done?
session? Yes, we'll
Yeah.
start with the next session.
Okay, thank you so much. I can ask him separately on WhatsApp some
Yeah.
questions. Okay, thank you.
Thank you.
Thank you.
Thank
It was a wonderful session. Thank you so much, sir, for joining. Thank you,
Thank you.
Dr. Gopinath. Thank you. Thank you, all the chairpersons. Thank you.
Thank you very much. Thank you.
Thank you. Thank you, sir. So our
Thank you.
next talk is about oats, what every gynecologist should know by Dr. Kedar. And for this, I would like to invite our chairpersons, Dr. Radha. Yeah, please show Dr. Radha's CV. Yeah, madam has done PhD in the field of reproductive medicine and surgery. She's secretary Tapisar. Many awards to her. And our next chairperson is Dr. Nilesh. He is clinical head and fertility specialist, OSS Fertility Pune, and regional medical head, OSS Fertility India, and is second joint secretary MOX, general secretary POGS, treasurer MSR, and many awards to her credit, and many national and international publications. Welcome, Dr. Nilesh. And
Thank you, ma'am.
Dr. Kalyani Shrimali. Dr. Kalyani is here.
Yes, I'm here. Yes, I'm here. No
Dr.
problem.
Kalyani. Yeah, she has 17 years plus years experience in infertility and reproductive medicine. And she is specialized in RIF cases and poor responders in low ovarian reserve patients. And she has done 6,000 plus oocyte retrievals and embryo transfers. Welcome, Dr. Kalyani. So over to you, chairpersons. Let's invite our today's speaker of second session.
Dr. Kalyani or Nilesh, please start. Nilesh, you're muted.
Yeah, can
Can
we
I
have Kedar sir
begin?
speaking? Hi, good evening, sir.
Hello.
Straight, I would like to thank Team ISAR, for inviting me here for today's wonderful ISAR Pulse session. Both the conveners, very good mentors and friends in Poxy and ISAR, Dr. Pesi Lewis and Dr. Anu Agarwal. Thank you so much for the invitation. My pleasure to invite again, a person who we look up to in Maharashtra chapter ISAR and also in National ISAR, Dr. Kedar Ganla. He is the consultant fertility specialist in Mumbai. He has his own fertility center and he also has his own ART bank. Of course, we do take donors from him. Wonderfully managed, precisely on this fulfilling all the legal norms. And we have it was my pleasure to work under him as treasurer when he was the secretary of Maharashtra State Chapter ISAR in the years 2023 to 2025. He was the joint secretary of Mumbai OBGYN Society in the current in the last year, and the past honorary general secretary of ISAR. He's practicing for more than 28 years now, and he has numerous national and international publications to his credit. We also know him as a ardent speaker and a very good orator. So, sir, we welcome you. The dais is yours.
Thank you. Thank you, Nilesh, for your introduction. And I have precisely 23 minutes by the clock to finish the lecture, unfortunately. But that's all right. Let's see how much I can go and how much I can do. So, as a male infertility, I realized in 2012 that very few andrologists exist in the Mumbai itself. And if you have a male infertility lecture or a patient, you do not know how to go about it. So it's better that you should learn on your own how to evaluate the patient. So at the onset, I would like to thank Dr. Amit Patki, Dr. Asha Bakshi, Dr. Sunita Tandulwarkar, Dr. R.G. Patel, Sunil Jindal, Dr. Gopinath, and everyone. And for them, I think this is what I expect to have. Congratulations and thank you so much. So this is the scope of my discussion of my today's lecture. And when you look at 50% of infertile patients will have 50% as a male factor. And if you look at with the advent of ICSI, what happened is the very little attention was given on the medical or surgical intervention of treating the male infertility. And hence, after a certain success with ICSI, there was a plateau in the results. And then we realized that the sperm also needs to be optimized before we go ahead with ICSI. If we look at the falling sperm count in the years to come, so many years to come, has resulted from many things. One of them is the endogenous source as varicocele and Sertoli cells and immature sperm. I think varicocele is the one which would come with the aging process. So later they are planning, the more varicose will be seen. Most important would be the environmental pollution, radiation, unhealthy diets, and lifestyle factors, which I'll cover later on. So when you look at them, age above 45 in male infertility with comorbidity, with diabetes mellitus or hypertension or obesity can have issues like genetic abnormality. If duration is more than 5, job profiles, we know IT personnel, radiation. Alarmingly high number of patients are getting diabetes and hypertension. And about all the patients of about 35 years, we are getting about 30 to 40% of all our patients getting diabetes or hypertension. This is all on the rise, especially the obesity, and sexual dysfunction is something which you have to take care. Now, radiation and male infertility, look at the laptops which are kept, and all these cellular phones, cell phone towers, wireless radiation can affect anterior pituitary, Sertoli cell, and result into low sperm count. Now, if you look at the previous slide which I showed from 1970 to 2020, these things have come into the picture and resulted into a deleterious effect on the sperm count. Again, radiation can result into distorted sperm head and DNA fragmentation and mitochondrial sheet, which contains into the tail aspect, which affects the motility, which leads to apoptosis. The mobile phones has electromagnetic radiation, The heat and the ionizing radiation will all affect the outcome. Another thing is I have tried to cover all the publications within last 10 years. So they speculated to keep the mobile phone in the shirt pocket and not in the trouser pocket so that you can die of heart attack and not of male infertility. Now, paternal aging, very few people give importance to this. So anybody above 45 will have all these genetic abnormality and associated with comorbidity like obesity, diabetes, hypertension. These all things can start very, very early as 30, 35 or 35 and above. The most important papers say the current literature shows autism, schizophrenia, and psychological morbidity in these subtle abnormalities are seen in the offspring of elderly paternal or elderly men who are taking treatment to us. As we know, smoking can cause decrease in the sperm count. Is somebody who is smoking, I think first they have to stop smoking and then only enter, because otherwise there becomes an increased risk of abortion into the female partner. Alcohol, not a very big problem in India, but if they are an habitual daily drinkers, then definitely yes, low FSH, low testosterone can cause decrease in the sperm count. Now, new thing on the block, microplastics and nanoplastics, both are now seen in the testes, in the brain, and whichever organ you say, causing reproductive dysfunction. And you see here, as a child, we start with plastic. Look at the plastic everywhere. Everywhere we are surrounded by plastic. And on top of it, we are putting them into the microwave. That also was going to kill the sperm. So the investigations are going to be detailed semen analysis, which is going to look at the count, motility, morphology. And if there is defect, then you will have to repeat after 3 months. HIV, HBsAg, HCV viral marker is a must before doing any intervention, as these are very important medico-legally. Above 35, sugars and lipid, and if obese, look at the hypertension. So WHO 2021 classification now say count of 16 million and progressive mortality of 39%. Most important is a standardized laboratory. That is what is most important. The pathology laboratory should have a counting chamber. Abstinence should be at least 2 to 7 days, but nowadays I compile it to 2 to 4 days. When you want to judge a response to a therapy, say a patient of 10 million, you have given any kind of medical therapy, you have to wait for 60 to 72 days for completing one testicular cycle. And the other cycle is from once the sperms are out from the testes, going to epididymis and ejaculatory duct is about 12 to 21 days. Now, as previous speaker gave his own experience, I like to explain something with my wonderful video. I hope you enjoy this video. So this is a gentleman sitting in the bar, and he calls the waiter and requests him something very important. Okay. Here he goes and tells the lady very politely. She's very happy that handsome man is giving her some request. And he tells her to move around so that he can see the girl behind it. So men are men, so do their sperms. So what are these? These sperm analysis, what you're doing, are on the basis of the concentration, mobility, and morphology, which may not have a direct implication on pregnancy rate. So what I'm saying is, a person of 10 million sperm count can impregnate his wife, and somebody whose count of 120 million may not be able to impregnate his wife because of poor predictability factor and subjective. and poorly standardized. Subjective in the sense, in the pathology laboratory, who is sitting behind the microscope and what report is giving. And on that report, you are going to do a laparoscopy and extensive surgeries for female, I think needs to be stopped at immediate effect. So now looking at total motile sperm count is something which is very important, which helps in overcoming the spermatic abnormality. So what we do is volume of the sperm with total motile sperm and percentage motility you take. And if you have a pre-wash total motile count more than 5 million, then only try IUI. If it is anywhere less than 5 million, please refer to higher center for further management. So let's take example. Somebody's got a 10 million count, 2 ml, 30% motility, count is 6 million. Well, one can try IUI. 5 million count, 2 ml, 20% motility, total motile count, 2 million. Patient state has to go for ICSI. Or 10 million count, 4 ml, 50% motile, definitely can go for IUI. So total motile sperm count does help. Now, as compared to the routine analysis, the new AI is coming in a very, very big way to give us the more standardized report, which are extremely costly. There are implementation challenges which will replace the job of junior embryologist. And also there are difficulties in differentiating the particles and the pus cells and the sperms. And especially I had experienced the motility which was seen on the microscope and the AI were not matching. The advantage is that it's accurate, consistent. Somebody who has got 100 semen analysis gives faster and easy way of giving the reports. Now, another one is where you want to know in total asthenospermia, you want to know if the sperm are motile or not motile, or they are completely immotile, so they are live or no. You do a Horse test. You put it in normal saline and you see the curving of the tail. If the tail doesn't curve, those sperms are dead. And only the sperm's tails curve, those sperms are alive. So this will give you a percentage of sperm alive in a non-motile sample, and you can decide how to go about the further management. Sperm DNA fragmentation. So both the strands of DNA are separated and resulting into the one arm and the other arms exposed, leading to abnormality in the DNA content. Now, this has got nothing to do with the semen analysis. Your semen analysis report may be completely normal, but your DNA fragmentation can be high or low. So this is what is the challenge, that 10 million sperm count person can make the wife pregnant. So if the DFI is less than 15, don't do anything. If DFI is more than 30, then there is a low fertility potential, and also there are low pregnancy rate and low IVF conception rate. Now, when you look at the pregnancy rate with IUI, IVF, and ICSI, you have with high DFI almost similar pregnancy rate, but clinical pregnancy loss, that is the early abortions, are extremely high with high DNA fragmentation. So in recurrent pregnancy loss, now there is people are considering to include the male factor and to do a DNA fragmentation test. So again, DNA fragmentation, high DNA fragmentation associated with early abortion can negatively affect the count, vitality, and normal morphology, but it can also affected by age, unhealthy lifestyle, and abstinence. Now, what happens is there is a sperm which has got DNA fragmentation. There are two things can happen. One, it may fertilize the oocyte, or it may not fertilize the oocyte. If it fertilizes the oocytes, then maybe there is a normal offspring because The oocyte, if the age is very good, younger oocyte, then it may compensate. It may compensate. But if there is an abnormal oocyte also, can result into an abnormal offspring, which results into an abortion. So additional diagnostic test, somebody thinks something like sperm DNA analysis, which can help to identify the DNA fragmentation test. So have we found the final test? Actually, no. What test we are doing is one of the lowest standard DNA fragmentation test. The highest standard test is the tunnel test, which is actually not available in Indian continent. Now the optional test, physical examination के बाद, to conclude with the patient, I do an ultrasound to confirm varicose seal. I request the radiologist to make the patient stand and let him cough to look at the impulse. Karyotype, so in recurrent pregnancy loss and severe oats, to look at inversion or translocation. Y chromosome microdeletion only in patient with severe oats, and if he's got importance also, so doing a prolactin. Genetic testing, karyotype, Y microdeletion, it's a very important. In Y microdeletion, if you have mutation of AFZA and AFZB, you are going to get somebody who's got azoospermia, which is not going to be improved upon. But the mutation is going to be on the C arm, then it may give you semen. So in these boys, the sperm may be there when they are young. As the age progresses, they will slowly move into oligospermia and then testicular failure. The surprising factor of this is the FSH is normal in these patients. You may think he's got azoospermia, FSH is normal. Giving medical treatment will help. It may not help at all. So one has to be very careful of doing this Y chromosome microdeletion. And also it's important that if he's got oligospermia, the parent should know that this particular pathology can be transmitted to the children or the male child, which also can become a carrier of Y chromosome microdeletion. So they have the choice of whether using their own sperm or not to use their own sperm. So we look at the history, physical examination, sperm DNA fragmentation, conventional semen analysis, hormonal assay if the sperm count is less than 5 million, and genetic testing only karyotype and Y microdeletion, scrotal ultrasound and transrectal ultrasound if the volume is very low. Now, what are the treatment options? First is the lifestyle factor. So we all know it's very important. But what happens is majority of the time, the woman who comes to the clinic, and we hardly take any history of these kind, which are very important, that these psychological factors, this may be undergoing, or diabetes or obesity or a radiation exposure is hardly talked about. So will daily sex help? So going back to the old time, maybe, 200, 300 years ago, they did not know anything about ovulation time, but their fertility rate was higher than us. See, 20 to 25% reduction in the DNA fragmentation if the abstinence was less than 1 to 2 days. So many centers nowadays with repeated IVF failure or ICSI failure, they ask the patient to ejaculate in the morning, give one sample, and around the time of ICSI to collect second sample, so that the amount of DNA fragmentation is very less. What I tell my all patients to have sex 4 times a week, whether it's a IUI or IVF, so that there is a automatic improvement in the DNA fragmentation. This happens by reducing the duration of sperm transiting into the epididymis and exposure to ROS, which is in the seminal plasma. Now, this particular paper was done in Netherlands. 118 men were told to ejaculate every day for 7 days. No drugs were given, no lifestyle changes. 80% of the people showed improvement in the semen parameter, which was very important. Lifestyle important factors. You treat obesity and you get results. When did you see this? During COVID times, where we had hardly any option of treating the patient, but tell them that they stay together, have sex, and reduce weight. And that give them fantastic pregnancy outcome. Now, this is the condition of India. Rising obesity. And do we have this kind of activity by the government where you tell people how important it is to lose weight? So this was done in Paris, where patients were asked to do a bicycling. And when they started cycling, they started seeing the lights. And that came up by so men also is very interested. So instead of making a exercise based, it's upon the weight loss in a very simple way. So see, very simple way. There was another way of doing is one of the railway stations said you do 15 sit-ups and you get the railway ticket free of cost. Paternal obesity can affect metabolic and reproductive phenotypes. Most important, it is causing epigenetic changes in the spermatogonial cells. So the next generation is going to get affected by it, and bariatric surgery are showing extremely good result in improving the sperm count and pregnancy outcome after doing the bariatric surgery. Then comes the role of nutraceuticals, which are the important factors in treating the male infertility. So now when the FSH is normal, testicular size is good, but the count is less than 15 million, you have option of treating with clomiphene, tamoxifen, or aromatase inhibitor if the patient is obese, the testosterone is low, estrogen is high that time, or you can use HMG, SCG, or GnRH analog, or HUMA SCG. So when you look at the meta-analysis of clomiphene citrate, it says it associated with increase in sperm count as compared to placebo. Whether it improves the pregnancy outcome or no, that is not there in this study because it is not combined with antioxidant. So if it was given with antioxidant, maybe with the count, quality could have improved and resulted into better outcome. Again, letrozole, very effective in obese individuals where the testosterone is low, there is peripheral fat, and there is a high conversion of aromatase enzyme. So by blocking that enzyme, you can have improving the sperm parameter. And one of the answer to Sir's question of obese man with azoospermia, there are papers of giving letrozole and they have found sperm in the sample after 3 to 4 months of therapy. Surprisingly, when you look at this meta-analysis of 2015, 8 studies where in FSH was used in there was no cause found for low sperm count, and what they found, the pregnancy outcome, the sperm count, the sperm motility, and also pregnancy rates all shows improvement in the parameters. So basically, you need to evaluate your patient correctly, and you should know that this odds is because of unknown factor, and then only you can treat with confidence. So similarly, it is showing with recombinant FSH, it is showing improvement in the semen analysis. This is 2020 paper. European Clinical Guidelines shows improvement in the qualitative and quantitative sperm parameters and pregnancy rate, but in selected idiopathic azoospermia. This word is very important. Empirically, we cannot give to all patients because it's an expensive treatment. Now, whenever cell utilizes oxygen, it produces ROS. So in testicular tissue, if the ROS becomes more, antioxidant will become less, and this will result into damage of plasma membrane, that is the tail portion, that will cause lipid peroxidation, which will affect the motility of the sperm, and DNA fragmentation, which will affect the fertilization rate, early embryo death, and pregnancy loss. So how does the ROS increase? The lifestyle factors. In the laboratory, the sample is collected at 10 o'clock in the batch IVF, and ICSI is done at 4 o'clock. So in the lab, the seminal plasma gets enough time to have impact on the sperm. Environmental factors, we know pesticide and plastics are the important. Genital tract infection, chronic diseases like diabetes, and idiopathic, which we do not know the cause. The damage happens to two areas which are very important, resulting into oligoasteroid teratozoospermia. So vulnerable sperm will cause reproductive failure, and all these factors will result into a oats formation. So by giving antioxidant, 2024 review, Cochrane review said, improvement in the live birth rate. It's not only clinical pregnancy rate, it's the live birth rate which improves after giving antioxidant of Cochrane database. Then which are the antioxidants which are important? You are bombarded with every company that different antioxidant. The most important, the strongest recommendation is L-carnitine and coenzyme Q10. L-carnitine is cellular energizer, which improves the oxygenation by transmembranous transportation of oxygen. Very important in asthenospermia. And coenzyme Q10, given in a correct dose, can result into decreased DNA fragmentation. As we know, these things are still has to be proven, but nutritional factors as simple as folic acid supplementation. If folic acid supplementation deficiency can cause neural tube defect in wife, similarly, a folic acid deficiency can in a male can be responsible for abnormality in the semen. So what currently, because there are no head-to-head trials, now there is no head-to-head trial with coenzyme Q10 with folic acid. Hence, combination is recommended so that we will get the best benefit out of it. So when you look at glutathione or vitamin E as 400 milligram, evidence B, vitamin C, evidence C. If you look at evidence A, coenzyme Q10, 600 milligram, 100 to 600. For Indian continent, 300 milligram should be given. So when you give a combination, you'll check how much coenzyme Q10 is there. If that is only 100 milligram, it's not going to be useful. It's better not to give him. N-acetylcysteine, very little use this molecule, but it's evidence B, and folic acid comes in vitamin level C evidence. So there are other factors like protodiazine, astaxanthin, lycopene. These will keep coming. Unless we have head-on-head trials, we cannot keep changing the antioxidant unless they are the sponsor of your next HRA conference. So if you want to reduce DNA fragmentations, How do you go about? Short abstinence around 20%. Oral antioxidants can be anywhere between 66% to 20%. Varicocectomy again. Because of this, even though the count is not improved, the wife becomes pregnant in varicocectomy. When you do PIXI, anything with sperm sorter techniques will also help to reduce the selection of highly DNA damaged sperm and over not DNA damaged sperm and improve your pregnancy outcome. And as the previous speaker said, testicular sperm has the least DNA fragmentation. So if you have a patient of OATS, previously used ejaculated samples and failures, next time please use testicular sperm, which will help in improving the outcome. Another aspect is asthenodospermia. Count 20 million, A grade motility 0. Can happen in about 24% of the patient. And these are the causes of that. And what do? You give empirical treatment, maybe antibiotics, CoQ, Carnishore, and maybe varicocectomy with obesity management and repeated ejaculation would help. Now, this drug Viagra, we know this Viagra been used for all the time when there is a performance anxiety and Nilesh has to go to POGS society meeting and the sample is not collected. So he says, go give him Viagra and ask him to collect the sample after 4 hours by the time I'm coming back from the meeting. So there's something which then only we realize the male really does exist. But if you look at, there are studies in animal models and in vivo and in vitro. Oral administration of single dose of sildenafil 2 hours before the semen sample collection helps in improving the sperm motility. So this is very important from our embryologist perspective. So they get more motile sperm during ICSI to have a better selection of the sperm. Containing this is our publication in our journal, which is published, that use 50 milligrams of sildenafil citrate to improve the sperm motility. And we had improvement in the motility and rapid sperm motility, which helped in improving the outcome of the pregnancy. Now, another one, the new molecule on the block is myoinositol. Again, the problem with myoinositol is not giving adequate dosage. So 2 grams of myoinositol by this meta-analysis shows improvement in the motility of the sperm and increasing the pregnancy outcome. Now, we need to be very selective. We cannot give to every patient of asthenodospermia. We need to find the cause, and if it is an idiopathic cause, then only this will improve the outcome. Again, probiotics, very little talk, probiotics everywhere and everywhere. So here also in male infertility, probiotics have been given. I don't say you start using it immediately, but there are papers who are saying maybe it improves the sperm motility and improves the outcome. Till now, there are 8 papers are already published, which showing improvement in the parameters. So surgical management, varicocele ligation, grade 1, grade 2, no surgery. Medical therapy, improve the count, give the trial with IUI. Grade 3 varicocele. This is the mechanism by which the varicocele will cause increased reactive oxygen, increased temperature, hypoxia. And if you have a grade 3, grade 4 varicocele, no testicular atrophy, normal FSH, and if the count is more than 5 million, then doing varicocectomy will give you an excellent outcome in terms of pregnancy, provided the wife has all the factors normal for a normal conception. Subinguinal microscopic approach, the best approach when they did with the lens, less painful, and it spares the lymphatic and testicular arteries. I know in people in South, they use Dopplers to now identify the arteries so that the ligation of vein happens at this level to improve the outcome. So the meta-analysis of this particular varicocelectomy says improvement up to 33% as compared to 15 in control group. Again, in 2025, varicocelectomy improves the sperm parameters and helps in downstaging the disease. So it will improve the sperm parameters. So ICSI patient can maybe become pregnant with IUI, and IUI patient may become pregnant naturally, also can be happening. Now, when you're doing IUI also, it also has to be with gonadotropins. Remember, little hyperstimulation and 2 or 3 follicles has to be there for doing IUI. Whichever technique you use, it doesn't matter. But considering 2 IUI in one cycle can be considered only in male infertility. As you see in this particular case, if you have 2 IUIs, you have a better outcome in pregnancy rate as compared to those who have a single IUI. Again, pre-wash count, double IUI gives higher pregnancy rate as compared to the single IUI. Only when you have evaluated, you did first 2 IUI with HMG, 2 follicles, patient not conceived, young patient, then third or fourth cycle you can do 2 IUI, not from the beginning. So this study found 2 IUI is cost effective and improves the outcome in low resource setting. Now, semen cryopreservation, something which has come up very, very beautifully. The husband not available at the time of IU or IVF, which can happen before radio and chemotherapy. Secondary testicular failure, you know that the FSH is rising, the count is going down. And most important is the performance anxiety. So we take all patient sample in IVF ICSI patient, a backup sample before going ahead. And for donor insemination, you have severe azoospermia or severe oligospermia, where couple has attempted many cycle of IVF and not conceiving, or they're not affording, or previous failed to fertilize, significant genetic disorder, sexually transmitted disease, or a single woman, you can do donor insemination. Always remember to do these tests, well-informed consent every time at the time of insemination. The most important, to get the semen sample is the patient's responsibility. It is responsibility of the ART clinic to involve the couple to get the sample from appropriate ART bank. Please do not get involved into this process tomorrow, because this can affect the outcome. And the donor has to be anonymous, preferably, but the current guideline says yes, you can use the known sample. Forget this. So now mild to moderate oats, you take 2 samples 6 weeks apart. If there is oats, you do serum FSH and blood sugar. FSH elevated, which means the patient is going into testicular failure, do semen freezing and proceed for IVF. If normal, try IUI or medical therapy. Blood sugar is something which I have come across many patients nowadays. Without even looking at HbA1c, people have gone ahead and done ICSIs, which will result into genetic and cardiac abnormalities and malformations in the children. So please take multidisciplinary help to improve the outcome. Clinical examination to do varicocele, if varicocele grade 3, treat it and then go ahead with IUI. So serum FSH within normal limits, lifestyle modification, antioxidants, weight loss, repeated ejaculation. Then you try CC, letrozole, gonadotropin, wait for 3 months, repeat the semen analysis. In the meantime, evaluate the wife. If she has PCOS, low ovarian reserve, maybe whatever it is, you evaluate that, then give 2, 3 cycles of IUI with gonadotropin with combination of oral ovulation made with two IUIs in one cycle, not conceive, then do ICSI with sperm sorter. Now comes severe odds, the count less than 5 million. Here, our role will finish. The patient has to go to IVF center. Serum FSH, blood sugar, Y chromosome microdeletion. Serum FSH elevated, semen freezing. Normal, may try doing this, but remember, Y chromosome microdeletion present will have serum FSH normal. So don't be under the impression that this is going to help. Please tell the patient to do a semen freezing. If chromosome microdeletion negative, then ask them to go for IVF ICSI immediately. Testicular PRP is something novel and experimental. So treatment option for high DNA fragmentation, oral antioxidant, varicocele repair, lifestyle management, recurrent ejaculation, new sperm selection techniques, and testicular sperm for ICSI. This is the new technique, which is a sperm starter, which helps in improving the better outcome. Very simple. You put the sperm here and the only good selected selection so this will give improved outcome, or you can do physiological isolated ICSI or IMSI, which will time consuming, which shows abnormal sperm and takes a little longer time to perform. Ideal sperm, testicular sperm, as the previous speaker has said. Now is the last topic of intratesticular PRP. Okay, everybody is doing PRP in hair, in the ovary, in the uterus. So what about testicular PRP? So if a previous 1 micro TISA is failed and you do PRP, you might get 20% chance that you will get the sperm in second micro TISA, a live birth rate of 10%. If you have 2 previous failed TISA, micro TISA, you may get 8% chance that the sperm will be available. Now, this man with severe OATS, a study was performed which showed improvement in the sperm parameters in compared to sperm concentration, morphology, and sperm motility. Now, the effect of platelet-rich plasma, 2021 paper, improvement in the sperm concentration in 54% of the man, and testosterone level also increased by 2.4 times. Now, this is our experience of intratesticular PRP. This paper is already accepted for publication. 41-year-old man trying to conceive since 5 years. Wife 33-year-old, HbA1c, TSH, prolactin normal, normal BMI. We confirm that is Y chromosome microdeletion absent, total Doppler normal. So the PRP, the mechanism of action is by cell growth. There is this improves the sperm motility. VGF again improves the sperm motility. So this is the technique by which we did the injection of 0.1 to 0.2 cc of PRP in 20 to 30 parts of divided parts of. After the procedure, I did not have to use any scrotal bandage, only for 1 day, antibiotics for 5 days, oral antioxidant continues. In our patient, after 3 months, the count from occasional motile, non-motile to 14 million and motility improved to 45%. Surprising thing is the FSH, which was 20, came to 9.5. So, well, after 6 months of therapy, Now the count has come down to 3 million and the FSH is steadily increasing to about 12 million. So this is the count which was pre-PRP. You can see hardly occasional motile, non-motile sperm here. And this is the post-PRP. You can see so many motile sperms in these patients. Well, till now I have done 5 PRPs. In one patient, they did not respond at all because his testicular tissue revealed only Sertoli cell syndrome. Rest of the things showed improvement, but nobody showed as good improvement as you see in these patients. So I think this is something which is very important factor which is remaining, which can be done. Maybe before doing micro TSA, if you do a testicular PRP, you may get sperm very easily and will improve the outcome. So in secondary testicular failure, this is one of the first kind of test and is published in Journal of Obstetrics and Gynecology of India, that is JOGI. So big future, maybe IUI and downgrade the treatment, but I will not say multicentric trials are required. Now, these are the two beautiful videos I want you to see. This is how Dr. Jindal and all the speakers and listeners here, this is how we show the improvement. Old man, just 1 month before Christmas. That's the Christmas tree. Can't lift up the weight. Next day. The day, final Christmas day. Just to pick up his granddaughter. He did this so much. So I think all of us has that spirit. We are the one who have been selected as a top guns. I think it's time for us to go back in the literature, have more discussions to improve our own knowledge and our knowledge of our colleagues. Thank you once again for giving your time. Thank you.
Thank you, Kedar. Over to chairpersons.
Yes, sir. Thank you very much, sir, for your wonderful presentation. You have covered the entire aspect of from the etiology to management and with the algorithm. It was a very wonderful session. So I just had a few queries. You said about the known donor. So what do we say for the quarantine period and checking for the viral markers again before we do it?
No. That is ART bank's responsibility. It is not our responsibility.
So you do because
no, it's not our responsibility. So that's why I say you don't collect the sample from ART bank. You don't make the selection. Tell them to go to the ART bank. Let them select the sample and get the sample to you. It is better. In long run, it is better. But if you want to do it your way, you can do it. But I would do this way. Because you are taking choice on the behalf of the patient. See, you have collected 25 semen sample and kept in your bank. Correct? If the patient says, I want A positive Hindu male, and which is BCom, how it is possible? How it is possible? It's not possible. You may not have that sample. So why do you want to get into medical legal aspects right now? Just don't do it. Tell him to go and get it. Somebody will get it.
Okay, because being in an institute, we still follow the anonymous donor.
I am saying that you should follow anonymous donor.
Yeah.
If you want to follow known donor, is a very simple technique. You ask the man to go to ART bank, donate the sample, maintain for 3 months quarantine, take his number. On the day of the ovulation, you ask the patient to go and ask that number. They get the same sample back to the lab. So you are not involved. Why do you want to do it for 10,000? Tomorrow, dispute happens between the family and the court case happens somewhere 300 kilometers from you. You will have to go to the court to tell them how did you do it. For that 10,000, you will have to spend from your own pocket. Don't get into that. मेरा भाई का भाई है, मेरा दोस्त है. Nothing doing. Everything now government will come down slowly on us. That is what I feel. So I don't do known donors. Okay.
Kedar, please stop sharing. Kedar, please.
कैसे करने का वो?
Stop sharing your slides so that we can see you.
Oh, okay.
And one more question, sir. Do you have any selection criteria for PRP testers?
As I told you, 1 minute. Stop share. 1 minute. So it's what I do is evaluate the patient correctly and come to a diagnosis of idiopathic oats. There is no cause found. Okay. There are hardly any test. Physical examination, varicocele, proper sperm count, FSH, sugars. Okay. And then you decide with the patient after giving medical therapy, no improvement, then you tell them to do a PRP. As I told you, my other 2 patients showed improvement in the motility, but not as good as this patient. Okay. So I still have a very little experience only of 5 patients.
And one more thing is you talked about clomiphene citrate. Do you measure the testosterone level 1 month after giving a clomiphene citrate to adjust the dose? Because in our practice, we are seeing the testosterone levels are going high. Say more than 1,000 1 month later. So in those cases, we reduce the dose of clomiphene citrate.
I give clomiphene 25 milligram, madam.
Yeah, we have
I rather try giving tamoxifen other than giving clomiphene. Tamoxifen 20 is much better drug than clomiphene because I have read one paper where 3 very low sperm count patients were given clomiphene and they became azoospermic after 3 months. And they had to stop clomiphene and the count came back to normal. So maybe the impact, maybe what you're saying is that high testosterone may be causing this.
So we normally
I'm not doing testosterone levels.
So we are measuring 1 month later and then we are reducing the dose either to alternate days like that. That's one thing we are doing.
But I think the more important thing is what made me realize the use of FSH in male infertility is the Bori Muslims patient. They are not allowed by the father, what you call is the padri. So they are allowed to do only up to IUI. And such 3 patients came to me and I treated them with gonadotropin, and with medical therapy and lifestyle management, 2 became pregnant, 1 did not become pregnant. So gave me the clue that why not try it in oats patients.
Okay. And one more thing is, do you give empirically the antibiotics, or do you do salmon culture or any other thing you can take into consideration before you start antibiotics?
At the beginning of my slide, there was written 28 years of experience. Not a single semen culture positive patient I've seen in so many years. Not a single patient, not a single report. If the reports are only not there, then what should I do? I'll have to give some empirical antibiotic. How do you give it for endometritis? Isn't it? There are n number of gynecologists treating in the similar way, giving doxymetro for 15 days and doing DNC, and the endometritis treated the older way. Now for males, this is the only way I look at it.
So what is your antibiotic of choice, sir?
Doxycycline.
Yeah.
Good answer.
I feel like Dr. Radha is taking my exam.
No, because there is difference of opinion among all the people, so I thought I should have an idea. I'm sorry.
But I'm loving it. Thank you.
Yeah. No, because there are so many controversies in that many of the books, they don't give that. So I thought I should. You have experience because you have been practicing with that. Thank you very much, sir.
Can I say something about this pyospermia?
Yes, sir.
See, the thing is that the pyospermia, definitely we used to do a lot of culture before. But because the now the thing, from where the pus is coming, that's the first question. It is a chronic prostatitis is the most commonly accepted cause of pyospermia or just inflammation. Okay. Now you do culture. Because even if the culture is sensitive, the vascularity of the prostate is very bad, and that antibiotic reaching the prostate is very, very unlikely. So even if you do culture sensitivity and give the antibiotics, it's very unlikely that it will have any effect. That is one thing. So the most accepted thing they are doing their cyclical antibiotic. One antibiotic, second another like doxycycline, then you give penicillin, then you give ciprofloxacin. Like that, they give 1 week each, along with prostatic massage. Probably that is what protocol we follow in these puzzles.
So regarding Kedar, regarding clomiphene, I don't use much of clomiphene, but most of the studies tell that you give for 25 days and give a rest of 5 days, so that suppression effect goes and that stimulation comes. So what is your experience, or how do you give clomiphene continuously, or
I give continuously. I've never tried this 5 days off. And to a real extent, we are going to start new study on this now. FSH before giving clomiphene and FSH and all the hormonal parameters after giving, so that we'll really come to know does it really help and what is happening. So in Indian continent, I will start to study. I'm just waiting for the initial write-up.
And there are some studies, original with letrozole was with the TE ratio less than 10. But there are some recent studies, one or two studies, they have tried for even other patients for a short term. That means 30 to maximum of 60 days of letrozole. But results are not conclusive. Any experience?
What experience I've got when I gave letrozole to the patient, very contradictory finding came to know that these patients started developing erectile dysfunction. I do not know. I did not do their testosterone, but they complained that they had little low sex drive. Okay, so I do not know. Ideally, it should not happen.
Should not happen.
It should not happen because the testosterone is going to increase. But I have found this finding, not very big data, but noticeably I noticed that yes, I tried this letrozole in non-obese patient also, but it not show. Again, the count doesn't become like from 7 million to 14 million. It will not happen. we need to explore the possibility of gonadotrophins. Otherwise, like how we do, mild control over and hyperstimulation, like that we have to do here and try. Maybe with dual things like CC and HMG, or Letrose and HMG, and then see for 3 months whether it improves or not.
We are seeing low level of estradiol levels, so that is one of the reasons for decreased sexual drive, libido in these patients. So as an institutional practice, some of the patients, when we are putting them on aromatase inhibitors, we do measure the estradiol levels also.
No, but then, madam, in male, the low estradiol, how it will be important in sex drive? It is the testosterone which will be the important factor in sex drive, isn't it?
Even high estradiol level, I mean, low estradiol levels are known to cause.
In men?
Yeah.
Okay. Thank you.
Maybe in patients with not T ratio not less than 10. Those patients may be patients.
Maybe. We have to do a study.
Dr. Kedar, one question regarding intratesticular PRP injection. Do you activate PRP before injecting?
Yes, I activate calcium gluconate.
Okay.
See,
And how much you put inside?
If you do not activate, okay, I personally feel that the platelet needs to be broken down.
Yes.
I have seen some presentations where they have shown platelet count before processing and after processing. After processing, there should not be no platelet, because your platelet has to break down. That factor has to be released. For that only we are giving activation. So that is something which is very important. The activation can be done. There is another method also, activation, which we are trying by incubating the freeze thaw is one, and incubating into the media, incubating into the incubator, so that the fibrin gets deposited and then you inject it. So that is something new, which I will tell you the details, but that also I have tried.
And how much do you inject?
Around 1 or 2 cc. It has to be, the testis has to be divided into vertically between the two halves, and on each side about 10 into each. So how the previous speaker said, there can be a simple isolated areas where the small spermatogenesis is going on. Luckily, if you hit that area, suddenly the proliferation will start and improvisation of the count will improve. 28 number needle I use, 28 number needle. And I'm not doing under block because I'm not very confident about my blocks. So I do it under GA. But this can be done under block.
Wonderful. So do we have questions?
Thank you, Kedar. That was an excellent information, because that is the area where a lot of people do, as Radha Madam told, different people do differently. So still a lot of learning things. That's why it's very informative. Over to you.
Thank you. Thank you giving me this opportunity, Anu.
Again,
I told Anu that two talks will take only 2 hours. Thank you, Anu.
Okay.
Yes, sir.
Sir, want to tell something? Sir, want to tell anything?
Thank you, sir.
Thank you, Dr. Kedar. It was a wonderful talk.
Thank you.
Thank you, sir.
Thank you.
And we will conclude.
Yeah, thank you.
Anu, please conclude.
Yeah. So we had a wonderful session today. Though we did not have a panel discussion, so it was a good decision not to have a panel discussion today. And we cleared so many doubts about male infertility, about which we are always puzzled what to do, what not to do. And thank you, Team UNS, for the wonderful cooperation.
Thank you.
Ma'am,
Thank
if
you
I
to all.
may give the closing remarks, is it okay?
Sure.
Okay, thank you so much, ma'am. So first of all, would like to thank all the esteemed faculty members for being present throughout the meeting. It's almost 9:30, but I see almost all of them because it was such an insightful, such an interactive webinar. Really learned a lot, even if we are working from the company's perspective. There's a lot that we learn with these webinars. So thank you so much. We were obviously honored to have Dr. Sunita ma'am, Dr. Ajay Patel sir as the guiding light, as the chief guest and guest of honor. And without any doubt, would like to mention the name of Dr. Sunil Jindal sir and Dr. Kedar Ganla sir for such amazing talks on oats on male infertility. Lots to learn again. Also, thanks to our amazing chairpersons for keeping the discussion so interactive, asking so many questions, almost resolving the doubts of all the doctors that are present over there. So thank you so much. And obviously, thanks to Dr. Amit Patki sir, Dr. Asha Bakshi ma'am, Dr. Anu ma'am, Dr. Fessi sir for their continuous belief in us as well. And thanks to all the participants for joining with us today. Thank you so much. Good night.
Thank you. Good night.
Thank you. Thank you very much.
Thank you,
Thank
Kedar
you,
sir.
Faisi.
Thank you.
Thank
Thank
you,
you,
Faisi.
Hanuman. Yeah.
Thank you.